Hey, today we're going to be taking a look at elbow treatment skills to follow up the last elbow assessment video that I made. And overall, just getting an idea of ways to manage limited range of motion, neurogenic symptoms, muscular weakness symptoms, along with working on coordination and the development thereof. Let's dive in. Okay, so we're going to start off looking at some myofascial techniques, just in general work on the biceps region, the triceps region, and the forearm. And so there's a couple things we want to consider when going into our myofascial techniques. Number one, we want our patient to be relaxed. Very important that if we're going to work on the tissues, we have as little tone as possible in them. So you don't want your patient's arm hanging off or something like that. You want to be supportive and calming, ideally, as much as possible. As you know from your palpation that's already happened before you get into your treatment, you have a general idea of where areas of increased tension may be. Now that is just one component of myofascial mobility. You also want to know about the fascial mobility itself, as opposed to just the myo component. That can be looked at through skin rolling, things like that, or by doing a rotational test or a superior, inferior, or lateral medial glide to look at the skin movement over the muscle through the fascia itself. But so in working through fascial mobility, there's a lot of very effective massage techniques that have been covered in prior material that can be used. Mostly, if you want to focus on the muscle, you want to apply a greater amount of pressure, as that's going to be better for reducing tone and downregulating the central nervous system. In the biceps, or in the antebrachial region and the brachial region, the antebrachial region and the brachial region, you're mainly going to be focusing on the biceps, the triceps, and either the extensors or the flexors, the lateral or medial epicondylar muscles. So getting a good pinch around the biceps and isolating them with a bend technique will be good for lengthening. The same with applying pressure at a fixed location where you find a trigger point. The patient has one right here, for example. Or another very effective technique that I'm a big fan of is to isolate the trigger point, apply a compressive force, and then move the patient through their range of motion. So you get that pressure distributed throughout the muscle as it goes across that point. And in my experience, it's been incredibly effective in dealing with trigger points. The same concepts can be applied to the tricep. You can do deep pressure or point pressure to work on a trigger point that the patient may have, or just to decrease tone. And you can apply compressive force. I have my index and middle finger on the medial side compressing, which you can't quite see, but applying compression, working through that range into extension, back into flexion, looking to maximize the range of motion that you're working through to decrease the tone there. Another very effective way is, for example, to put a bolster underneath the end of the elbow, work through here, perhaps a little bit closer to the musculoskeletal junction, but just to roll that across there. That tends to be quite effective in my own experience. Next, looking at the forearm flexor extensor groups. Due to their size, it is pretty easy to just get your hands around, and you can do muscular bending, you could do sustained pressure, like deep strokes, or you can work a little bit more specifically if you just use the general understanding that you have of manual muscle testing. You can typically identify which muscles in the forearm by palpation correlate to which muscles you understand anatomically and work on them more specifically. Say if my patient has a pronation deficit or a trigger point in their pronator, it's pretty straightforward to just resist their pronation, identify that muscle, and apply good, deep, sustained pressure. Or, similar to the concepts with flexion and extension with sustained trigger point pressure, identifying the trigger point, applying a sustained pressure, and working the patient through that motion to manage the trigger points across the length of the muscle. And that's going to cover it for soft tissue mobilization, and myofascial management. Next, we're going to look at elbow mobility related issues, specifically looking at manual therapy to manage those. So we're going to start off looking at a flexion limitation. We're going to be using osteokinematic motion first to look at this. So the general osteokinematic motion of going into flexion is one way that you can effectively look to manage a flexion limitation. Say if your patient had a limitation here, you can just a passive overpressure gently either distally is going to create a greater torque around the joint, or you can go more proximally, stabilizing the humerus, moving with that overpressure into the motion that you're looking for. Of course, something that you're going to want to consider to patients' bone density if they have a known history of osteoporosis or something like that. Going with a greater lever arm, while it produces greater force and may be more efficient for you, may be a bit of a risk based on the patient's risk for fracture. At the same time, we can also do some other components, or following up, we can do some other components. We can look at doing an anterior glide of the joint. And so on the radius or on the ulna, either one is acceptable, but just working, or depending on their limitation, you may want to pick one or the other. But getting a good joint position with a perpendicular force, coming in, stabilizing the humerus, and in this case, I'm going to get a good grip of the ulna, stabilize the humerus, and work into that flexion range with a little bit of overpressure to work on any limitations the posterior capsule may have through a stretch there. The same can be done on the radial side. A little bit easier to come inside of the patient's arm, stabilize the humerus, grab the radius, to apply that same flexion force with a good golfer's grip, as we talked about in my past video. One of the potential limitations you can see with these manual techniques is going to be at a certain point in flexion, your own arm stabilizing, or your own hand stabilizing the humerus may be a limiting factor as far as how far you can push. So you may need to either adapt your stabilization, or you can look at working into more mobilization movement techniques. You can use a bolster. In this case, I'm going to use a Expo dry erase marker in the antecubital fossa, and by having the patient flex over that, though you want to be considerate about the material you use, the marker's not going to be ideal. Ideally, you want something a little bit compressible but still firm so that it's not going to be uncomfortable for the patient. You can work over that bolster while stabilizing, and that's going to create a more of a ice cream scoop motion when you think about its rotation around kind of a modified axis. That's going to be even more effective at stretching the posterior capsule if there's a capsular limitation. So you can apply a good force, forearm perpendicular to the motion that you're applying, of course, so you get a good force arm through. That's going to be very effective at overcoming flexion limitations in motion. Next, we can look at elbow extension limitations. So just like before, we can manage those a little bit through the osteokinematic motion. So with a soft bolster under the arm, just to keep the olecranon off the table, prevent any kind of blockage from that. We can bring the patient's arm into extension. And of course, if there's a limitation, say here, with the arm stabilized, we can pull, applying a perpendicular force. Of course, being more efficient to push through the perpendicular force. One of the complications is appropriately distributing yourself across the patient, because you want to be able to stabilize the proximal, so you can mobilize the distal with better clarity. Getting your patient into that extension, you can apply some passive overpressure for osteokinematics and working into facilitating that extension. Of course, you can also move arthrokinematically on the radius or the ulna, looking at facilitating that greater extension. So for example, we can do a posterior glide at the limitation point on either side with a bolster under the elbow. A good perpendicular force, of course. In this case, I'm going to come in on the ulna, apply a good posterior directed perpendicular force to stretch that anterior capsule in the elbow joint, facilitate greater extension. You can do the same thing on the radial side. The humeroulnar and humeroradial joint both share rolls and glides and are both concave in the roll glide dimensions, so they're going to be very straightforward to apply forces for arthrokinematics and for joint mobilization. So those are going to be two pretty effective ways that you can go about facilitating that. You can also apply a more firm bolster underneath with your own arm. And the problem that you may run into with an extension like this is that you get humeral motion, as you can see there, but with any kind of external stabilization that you may have, it's pretty easy to apply a really good torque force there. Of course, checking in with your patient to make sure nothing's uncomfortable, and get a real good anterior stretch of the capsule. Next, we're going to look at pronation. So that'll just be pretty simply achieved through a medial glide of the radial side of the arm. So in this case, I'm going to tuck the patient's arm under mine, come on out here with the patient in full supination in this case, block the internal. I can feel the medial side, or depending on how I perform the glide, I can have a finger in the posterior radiohumeral joint to feel the medial glide, or I can palpate a little bit more medially, posteriorly, and I can feel the humeroulnar joint while I press through my distal metatarsal here, applying a good medial glide. You can see the ulnar angle there on the medial side right here change as I apply that pressure. You can see that little bit of varum force. Of course, trying to minimize any kind of shoulder rotation so that it's not a flexion moment. That's going to be effective at addressing any pronation limitations due to the medial motion that occurs there. You could also work on a anterior glide, a distractional glide, or a distractional motion to increase just the general range of motion of the capsule. In the same time, or in the same sense, going to work on a lateral glide, the ulnar side, to facilitate supination. And so this is going to work through the exact opposite kind of arthrokinematic motions that we saw when we applied a medial directed glide from the radial side. So in this case, just like before, I can palpate with my other hand, my index and middle finger coming through to feel the radioulnar joint posteriorly. Then in this case, I'm going to push with my hypothenar, or with my thenar eminence, get a good lateral glide here to facilitate the exact opposite motion. Of course, always wanting to be keeping your forearm perpendicular to the force that you're creating to maximize the efficiency, checking with your patient to make sure there's nothing too uncomfortable for them going on, making sure that everything's being done appropriately and they feel appropriate in the loop. Finally, we're going to look at a mobilization movement for lateral epicondylalgia. In this case, it's going to be looking at a Mills manipulation. So not quite as much as a synergistic technique as a normal mobilization movement, but still quite effective for working on that. So you want your patient's arm to be off the table. In this case, could you slide a little bit this way for me? Thank you, because you want to be able to clear the elbow. You're going to have your patient in pronation with a fist and the arm at 90 degrees. You're going to have your thumb on the posterior radius. There we go, just relax, relax. And as you bring your patient into extension, right before you reach the extension point, you're going to, similar to a drop home test in the knee, you're going to apply that extension force on the radius, pushing it anteriorly based on location. And immediately after you apply that anterior force, you're going to want to relax the wrist in order to prevent any kind of musculoskeletal injury that may occur from the tension and the positioning that's occurring. So we're going to come on out and apply that quick HVLA force anteriorly with the arm. So let's go through that one more time. Position 90 degrees of the forearm, hand in a fist, palm reflection, pronation. Thumb on the posterior radius. Come on down. Quick force, relax the forearm. And so that's going to be our mobilization technique that we're going to be using in the elbow, especially for lateral epicondylalgia, as it's going to be affecting the angle of the tendons as they come through, and through that, reducing the pain and sensitivity that's present in the radiohumeral joint. So next we're going to take a look at some neurogenic management of symptoms. In this case, it's going to be looking at ulnar nerve, radial nerve, and medial nerve pain. So first we want to discuss the two ways we're going to do that. We're going to use tensioners, we're going to use gliders. Therapeutically, you primarily want to use gliding techniques as they facilitate a full motion of the nerve back and forth. Kind of like a tug-of-war scenario as far as the movement of the nerve. It moves from side to side. Tensioners increase the tension throughout the nerve and have been shown to be less effective as a management intervention when compared to gliders. So we're going to focus therapeutically on gliders, but I'm going to demonstrate both. So first things first, we're going to start with the radial nerve. For that, you're going to need forearm pronation, finger flexion. You're going to want to make a fist, bring it all the way in, pronate the forearm, internally rotate the humerus, depress the scapula to really feel the tension on the radial nerve. And finally, bringing that neck away. And so, as a tensioner, what you could do is you keep everything distally static, move your neck, or you keep your neck static, move your wrist into greater flexion. Now, to use a glider, I would start in a tensed position, and I would relax the forearm as I tensed the neck. So in this case, I apply a pull this way on the nerve, centrally on the nerve, while I relax the distal end, causing its movement up the arm. And then I would flex the forearm at the wrist and relax the neck back into a central position so that I allow the nerve to move distally. And these together are going to be what you use to, these two motions together are going to be what you use to manage the symptomage on that nerve. Next, we're going to look at the ulnar nerve. So for the ulnar nerve, I want the elbow flexed, the wrist extended, the fingers extended. Just up like this, kind of like you're holding a dinner plate. As you depress the scapula and move your head in the opposite direction, you're going to get a tensile force through the posterior arm here, right through the location of the ulnar nerve. And the way that you're going to do a tensioner of this would be get it in max position, almost like you were trying to strangely put a hat on. Bring your head in the opposite direction, keeping that shoulder down. It's going to apply good tensile force through there and pull on that nerve. But what we really want to do is the glider, of course. So for that, as I move my head away and increase the tension, I flex my wrist towards my head. I do the opposite, just like this, pulling the nerve in opposite directions, allowing for that movement. Next, we're going to look at the median nerve. So we want to go into the same neck position, extension of the wrist, elevation of the arm, putting it all the way out with it following its path across the center of the arm. This is going to be a very sensitive position for people who are positive. All of these will be sensitive positions for patients who have positive symptoms to a varying degree based on the amount of sensitivity that they may have. And so, in exactly the same way, I can flex my wrist and bring my head back to midline for a glider, or I can keep everything stationary, move my head away for a tensioner. And of course, a tensioner can be performed at either end. You can keep your neck fixed, bring your wrist into extension, or you keep your wrist fixed, move your head back to midline. And so that's a brief overview of how we're going to look at management of neurogenic symptoms from the ulnar nerve, radial nerve, or median nerve. So now we're going to take a look at muscle length interventions. So these are going to be stretching techniques that we can use to increase the range of motion or decrease the sensitivity that these muscles may have to being fully extended. So in the first thing we're going to look at the biceps, your biceps brachii here. two heads, the long head and the short head. For the long head, we're going to pronate the hand, extend the elbow, and extend the humerus while keeping the scapula tucked tight. And so because the long head of the bicep goes from the supraglenoid tubercle down to the radial tuberosity, the pronation pulls it away. The straightening of the arm extends it, extends the muscle length. And then the extension of the humerus pulls it away from the supraglenoid tubercle. And so that's maximally going to be stretching the long head. For the short head of the biceps brachii, we want to be in a similar position, but with a little bit of a different extension motion for the arm. So we're going to pronate the forearm, extend the elbow. We're going to be looking at getting horizontal extension as it's going to, the short head of the biceps brachii is going to attach to the coracoid process of the scapula. So bring that right across. Of course, stretching, we're going to be looking for a cumulative 60 seconds a day, ideally in groups greater than 10, but 30 seconds is really our bang for our buck. So as far as patient prescription for these, I'd be looking for my patient to perform a stretch like this for about a minute a day, every day. And so that's going to be the most effective way to implement this kind of intervention. And a minute a day is not a lot of time. It's not a huge opportunity cost for the patient to take a minute out of their day to do these stretches. Next, we're going to look at the forearm flexors and extensors. So as far as the forearm extensors, attaching to the lateral epicondyle over here, we're going to be in a wrist flexion, finger flexion. So make a fist, flex the wrist, extend the elbow, and pronate the forearm. That's going to be putting the extensors across their maximal course that they can be put across. And next we're going to look at the flexors. So that's going to be finger extension, wrist extension, elbow extension, and pronation, pulling from the medial epicondyle here across and up through all the fingers. Of course, multiple ways you can vary this. You could have the patient with their hand against a firm surface like a wall, apply overpressure gently if they are just having difficulty actively maintaining that range, if they have an active insufficiency. Or for extension, you could have your patient make a fist, flex the wrist, and simply press down into a nice firm surface like I've got right here. Depending on the firmness, obviously you may want to be a little more gentle, but that's going to be the ways that we can really focus on stretching the biceps brachii, the forearm flexors and extensors. Okay, so now we're going to take a look at some exercises that can be used to strengthen elbow flexion and elbow extension. Exercise number one we're going to start off with is a classic. Everybody knows this one. It is the bicep curl. It's one of the most iconic workouts that has probably ever been around. You can think about the most iconic bodybuilders you can think of. Arnold Schwarzenegger, big bicep curl fan. But even just if you go into a general gym, you'll almost always see somebody doing a bicep curl. Effective way to strengthen bicep brachii. We have a couple other muscles we can think about with this. You can also think about, depending on the position of your hand, you're going to work different muscles. In supination, the primary flexor that you're going to be working is going to be the biceps brachii. In a neutral stance, you're going to get a lot of action out of your brachioradialis through here. And in full pronation, the most active muscle that you're going to have is going to be brachialis. So depending on the position of your arm, you can get more action of certain muscles. And so a couple of different variations of this exercise can be very beneficial to a patient. In this case, we're just going to go ahead and work on the supinated position for that biceps brachii. So we're going to start off standing nice and tall, shoulders back, relaxed down, a good grip on whatever your weight of choice may be. You're going to start off with your arm fully extended, get a good full motion, flexion motion here. If you want a little bit more biceps activity, you can flex the humerus or the glenohumeral joint to get just a little bit of extra motion you can get out of the biceps brachii. Of course, if you do them simultaneously, you're going to be using momentum to kind of minimize or reduce the impact that your biceps muscle is having on the motion, as opposed to full controlled contraction. So if you're going to do a little bit of glenohumeral flexion, or just classical arm flexion as people think of, you're going to get that full arm curl first, and then just a little bit of motion from it. Next thing we're going to be looking at is the bent row, another classic. So you're going to have your hand on a good, stable point. Bend the hips, not in the back. You want to rotate around those hips with a bit of a stagnant stance. You're going to pull your weight up towards your chest, pinching the shoulder blades together at the top. And in the case of working on elbow flexion, you're going to really want to focus on the squeeze of that bicep. Now, obviously, if you have a real heavy weight like this, you don't want to be pushing down on something super soft because you could break through it if you have a very flimsy table or something like that. So your environment does matter a little bit for these, along with accessibility to weights. But these are going to be two effective exercises for both strengthening arm flexion along with some other muscles peripherally. Next, we'll take a look at elbow extension. First thing we're going to look at is triceps extension. So I'm going to change weights for this. Going to move over to this bad boy, nice and heavy. And in this case, the first thing we're going to do is just general triceps extension overhead. So this is another very iconic exercise. Flexing that arm, flexing the arm, flexing the elbow, getting a good grip on your weight, and pressing it up towards the ceiling while standing tall with that abdominal contraction. Straightening the arm, focusing on that good, strong squeeze at the end. That's going to be an excellent triceps strengthening exercise. Now there's a lot of these, and this can be modified with a cable. For example, if you had a band or a cable that was attached to the ceiling, you could simply extend the arm down, which can be performed with a bit more control than using a free weight like this. And you want to pick something appropriate for your patient. You don't want to hand your patient a 15-pound dumbbell if they come in with elbow pain and have them doing overhead tricep press. You're going to want to give them a band and have them attach it to something and do that. But for the sake of what I can demonstrate here, I've got a lovely bottle of Fiji water and gravity to work with. So make the best of what we have. Next thing we can do is look at the eccentric dip. Eccentrics allow you to generate the most force with your muscles when used maximally, but in this case, we're going to be looking at a submaximal eccentric. One of the benefits of this is that you can use your legs to assist you and gravity to resist you. So you can really hone in on the level of intensity that you want to apply with this, assuming your patient has all the necessary strength to overcome gravity and take care of all that. So you're going to get a good position. In this case, I'm going to take the edge of this table here, but a good firm position that you can wrap your fingers around. Slide your glutes off. You're going to dip down nice and slow. When you reach the bottom, you can actively push up with your arms. But the benefit of this mostly is that you can use your legs to repel you and to slow you and drop. So for the eccentric component, we really want to focus on lowering as slowly as possible with as much control as possible. So again, got to start off just off the table, slowly lower. You can push through your legs to make it a little bit slower, gently drop on down, resisting that drop with your arms. And then when you reach the bottom, you can either actively push back up with your arms or with your legs. But that drop is going to be the most bang for the buck that we can get out of this exercise. Okay, so next we're going to be taking a look at paired exercises for strengthening supination and pronation. And so these are going to be very easy to work in with each other because as one motion is done, the next motion you can use to strengthen is exactly the opposite, very straightforward. First, we're going to look at a resisted supination, resisted pronation. So using this band, I can stabilize it distantly, get a good pronated grip on the band and simply supinate my hand. Depending on the band that you use, the amount of tension in the position of your arm. In this case, I'm going to be working at 90 degrees. Things nice and simple. But just doing that resisted supination is going to be good for strengthening my supinators. And then by simply changing the position of my hand to be inside, a little bit closer, and starting in supination, I can strengthen my pronators with exactly the opposite motion. So that's our first pair of paired supination pronation exercises for strengthening. Next, we're going to look at something that pretty much everybody has. That's going to be a screwdriver exercise. So screwdriver, screwing in unscrewing, a very classical supination or pronation motion. It's something that's pretty straightforward. First, you can go to Home Depot, buy a board, get some screws, and it starts off right off the bat at high intensity over here, simply fixing and rotating into supination to screw in. And then once you have a screw all the way screwed in, you simply unscrew it into pronation. Of course, the exact direction that you're going to be turning the screwdriver to screw in and out is dependent on the threading of the screw, but regardless, if you screw a screw in and then unscrew the screw, it is going to work both supination and pronation as a good resisted exercise, mostly working on endurance at that point, but depending on how tightly you screw them in or how many threads there are, the intensity will scale and it can become a decent strengthening exercise or supination pronation. So, like all exercises, the prescription is going to be based around what our intent is. If we want to strengthen, we want to be looking at a lower number of reps and a higher intensity to create the kind of environment that is going to be facilitatory of the intercellular changes that are going to cause strengthening, like hypertrophy. If we look at more endurance-based things, if your patient, for example, is a carpenter and screws things in for all day, we're going to want to go for a higher number of reps and really focus on the quality of motion, refining the changes that they may have or the issues that they may have. So for strengthening, 4 sets of 8 to 10 reps, or 8 to 12 reps, going off the ACSM guidelines is going to be ideal. Taking that rep range up to about 15 for 3 sets is going to be the prescription that we would use for the endurance aspect of a patient. Power training, probably not what you're going to be doing for supination pronation, flexion extension, unless your patient is doing dips to stand up or something like that, pushing on the handles of a chair to facilitate that upwards motion into standing. But they would run, the biceps flexion extension will have the same kind of parameters for strengthening and endurance that you would see in the forearm supinators pronators. Okay, so next we're going to take a look at a pair of coordination or functional retraining exercises to work on elbow coordination for functional tasks. If your patient is a fisherman or a cowboy, these may be especially functional, but these may be also a lot more hobby-based for the development of coordination there. First things first, we're going to look at casting the fishing rod. I have to back up a little bit so I can actually get something in frame, but having your patient work through preparing everything for fishing, along with a side cast in this case, with the extension and ulnar deviation, or with specifically the ulnar deviation of the wrist, and the control of the elbow going into extension, along with the gentle pulls that you may see to really refine the catching process while they're fishing. Going to be an excellent overall task to work on coordination and functional aspects of the elbow. Of course, this is variable by several things. The extent to which you extend the elbow and the intensity with which you extend the elbow determine how far the fishing rod and the bait is cast. So this can be easily done by any clinic where there may be a body of water, especially if you happen to fish out there every now and then. Very straightforward way to do it. This is also something patients can do on their own time. In Florida, it's not too hard to go to the beach, to a lake. I have a canal in my backyard that you can go out to and practice this at pretty straightforwardly. You could either measure it out for their home exercise program, 5 casts at this range, 5 at the next, or just have them go out and enjoy some fishing to work on the quality motion coordination of proprioceptions present with that. Next, we can take a look at another option. If your patient's a cowboy or some other profession that involves lassoing or has whips in it, which is admittedly very few, but still a functional task. You can, in this case, I have a makeshift that I crafted out of a towel. The extension, wrist, the elbow extension, wrist extension, and the flexion have to be very specifically timed in order to produce the classic crack of the whip. In this case, I'm going to try to avoid the very loud sound because my classical patient demonstration, and lovely assistant is asleep, and she has work in approximately 5.5 hours, so I don't want to interfere with that. But in this case, I'm going to be targeting these here sacks of corn. So with the appropriate wind up, elbow extension, elbow flexion to create that peak inversion of the width. Very specific coordination necessary for this. Excellent proprioceptive development along with a little bit of reaction time. So obviously, as you can see, I need a little bit of help. That and so as there was an excellent example of a prime reflexive flexion moment there in the elbow to generate that hit and that pop just the right range. So not only does this work on the elbow coordination itself, in the sense that you have to extend and flex, but you also have to gauge the range through side shifting, lateral weight shifting, and know when to alter those in the motion. So it very thoroughly functionally incorporates elbow flexion extension. Another good example that could be given is going to be whisking, supination, pronation, involved in whisking, baking cookies from scratch, something like that. The patient, at the minimum, they can enjoy the end result, hopefully, as long as they follow the recipe. But the whisking motion of stirring the bowl is going to involve the supination and pronation aspects, working on getting to the full range of the bowl, especially to be a good whisker. You need to start either inside or outside, but you need to work through the full range and not let anything stay at the bottom. Kneading dough, a very good example. The turning over of the dough that's far away, pushing under, getting the forearm supination, pronation along with the extension and flexion force in there are going to be just some very easy alternatives that can be used, and also that are very functional for performance of activities like these and development of that coordination and increasing function in a patient who has a elbow issue. Thanks for stopping by. Feel free to like and subscribe. I put out new videos every time they're assigned.